Stuff, just a little bit about myself. As she said, I'm a certified nurse midwife. I got my bachelor's from the University of Wyoming in 19-something. And I immediately became an OB nurse and did that for about 12 years. Did childbirth education, did lactation consultant, all those things that kind of go along with that. And then went back to get my master's, and I got a master's degree from Case Western Reserve in Cleveland, and a master's from Frontier University in Kentucky. And then I received a certification in nurse midwifery and a certification in women's health nurse practitioner. So I worked at College Hill Health Center. You guys probably, that's over and done. I've been now at our own practice, Health Dimensions Clinic, for about 1.5 years now, and I work with a second midwife as well as a family nurse practitioner, and we'll be adding a new family nurse practitioner here at the end of the year, as well as a OBGYN physician. So our primary focus is to provide women's health care, and we do OBGYN as well as women's health. Just a little bit about what CNMs are. I think there's a little bit of confusion about that. Certified nurse midwives do have master's degrees, and then they have additional certification in nurse midwifery. There are several different levels of midwifery, and there's professional midwives, there's certified midwives, there's direct entry midwives, and then there's lay midwives. And so there's all different levels. Your certified midwives and your professional midwives generally don't have a master's degree in nursing. They generally have some type of degree, and then they go into a program to become a midwife. Your lay midwives are the ones who probably watched a YouTube video and then said they were a midwife. so they don't have any official training, and they aren't required to have any type of educational background. There is groups that they are registered with. There's the North American Midwifery Association. There's also the NARMS, which is also an accrediting type of thing where they basically send in their information and say, this is what I've done to be a midwife, and then they're registered basically. So certified nurse midwives in the state of Wyoming are governed by the Board of Nursing, and we are considered advanced nurse practitioners, and we have prescriptive authority and of course have to follow the guidelines of the Board of Nursing. There is a Board of Midwifery in Wyoming, which has been established since probably about 2011. Anything below a certified nurse midwife were not recognized until about 2010 in the state of Wyoming, and they didn't have this board until then. The Board of Midwifery falls under the Board of Health, and so they're not they're not under nursing protocols. So that's the difference between midwives, lay midwives, nurse midwives, because there's a lot of confusion about that. Nurse midwives are independent. We practice independently, where we can most nurse midwives do their deliveries in hospital settings or birth centers. There are some nurse midwives that will perform deliveries in a home setting. Only problem with home deliveries is the fact that you can't get any malpractice insurance. And so that you're practicing pretty bare, and so you have to take on to that risk. And so, but there are probably 2 to 3 midwives in Wyoming that do home births, maybe 4. It varies. There are midwives that come from out of state and can do home births in the state as well. So, but as a nurse midwife, I choose to do home, or I don't choose to do home births, and all my births are done at Memorial Hospital here. So I guess the scope of practice for nurse midwifery, as I said, involves women's health as well as OBGYN. When we talk about women's health, we go from adolescence clear up to through the end. You know, our focus is in nursing as in midwifery as nursing. Our focus is the patient and the patient's health and being empowered to take care of themselves and to take care of their own health and to be the best they can be. So a good share of what we do is education and support, but also providing the primary care that's necessary for many women. You'll probably note that most women will go to see a provider when they're pregnant and when they hit menopause. Otherwise, they won't go in, they're too busy, kids got to go be taken care of, things got to be done, and they don't really take as much time for themselves. So as women in general are somewhat of a high-risk population in that we just don't take that time because we're busy taking care of everybody else. So, so we have to, when we do our care for our women, we try to be all-inclusive. We do annual examinations for women, and our annual examinations aren't just a breast exam and a pelvic. I mean, we do a full range because chances are that woman's not going to go see anybody again unless she's got a cold and she'll hit Instacare. So, because it can be fast and she'll be in and out. So, probably antepartum care, if we're talking about OBGYN, so antepartum care, which is prenatal care, we generally provide those starting in the first trimester, somewhere between 6 to 9 weeks of pregnancy. Antepartum care involves, of course, the blood work, which we check to kind of get a screen on those women to see what we're looking for in the terms of their blood type, their RH, varicella, rubella, all those things that could affect the pregnancy in some sense. So we get baseline to see that we have a normal patient. If we had, at that time, with assessment is probably the number one most important thing with midwifery care is, and taking care of women in general, to determine if they are at risk. We like to think that every pregnancy is healthy and normal and it's a natural thing and everybody's going to have a great pregnancy. Well, they are, we hope, and we try to evaluate for those types of things that we need to watch, we need to be closer on. Because again, majority of pregnancies are going to be normal and healthy, however, you're going to have that percentage that aren't. And those are the ones you have to catch, and that's our job is we're experts at normal, and we're experts at finding things that aren't normal, so we can do something about those and refer them if we need to. Okay. In taking care of those women, ultrasound, we generally try to get one in the first trimester. There are, in my practice, depends on, we either send them to radiology to have an ultrasound done. I generally do all my own ultrasounds for my patients, and so it's kind of a cool part of doing what we do because we get to see the babies all the time. So ultrasound I like to get in the first trimester. The earlier an ultrasound, the more accurate it is. And so, if we get an ultrasound at 6 weeks, I can date a woman within 2 days. If I get an ultrasound at 20 weeks, I can date them by 2 weeks. Wow. And third trimester, 3 weeks. So genetics kick in after about 16 weeks, so you're not as accurate. So we like to get those first trimester ultrasounds to determine that we're accurate for due dates, and therefore if we have changes in growth or things start to skew, then we know it's not because we are off a week on our period, in ovulation. So ultrasounds are a part of that. Genetic screening is something that we will offer women. Usually the genetic screen by chromosomes are done generally between 9 and 11 weeks. We can do it that early. We usually reserve those testing for women who are a high risk. If they have a genetic disorder in their family, if they are advanced maternal age, that increases their risk significantly of genetic disorders. A woman who's 40 has a risk of a Down syndrome maybe of 1 in 200. A woman at 45 is 1 in 20. So that risk increases quite substantially. So genetic screening is usually something that's recommended for those women. Those second part of the genetic screening, that can be the early one for the high risk. We can do screening at 15 to 19 weeks of just a general for neural tube defects, for Down syndrome, trisomy 18, we can do those between 15 and 19. Those are just screening tests. However, they're not, if we get those abnormal tests back, then we have to do further testing. Whereas the chromosomal testing we can do between 9 and 11 is quite accurate. 20 weeks is generally an ultrasound to check for anatomy. We check for cleft lip, cleft palates. We check for heart deformities, bowel, brain ventricles, pretty much everything that we can look at, placenta location, those kind of things. So that's a general ultrasound at 20 weeks. We move into the second trimester where we screen for gestational diabetes, and that's something that can be a problem at birth. If you hear of women having 13-pound babies, it's because they had diabetes and they didn't get treated. Okay, so we try to avoid those kind of situations. It's not only a risk for the mother, but it's also a risk for the babies as well. We check for anemia, which is always a prevalent thing that we see in the second trimester. All women drop their iron levels in the second trimester, so we check for that at 28 weeks. And then the third trimester, of course, we're just monitoring for risks. I mean, we see an increased risk in preeclamptic symptoms, increased risk in hypertension, increased risk in growth restriction, those kind of things in the third trimester. So we're screening those women pretty regularly with blood pressure. We check their urine, we check growth of the baby, all those kind of things in the third trimester. So we see the women much more frequently during that time frame. Birth, of course, we attend births. That's our job. That's the fun part. So we try to encourage spontaneous births. Spontaneous labor is the best way to go. We have a much less risk of cesarean delivery if we have spontaneous. With managing labor, we have to look at, we've got 2 patients there, so you're responsible for not only monitoring a mother, but you're also monitoring a baby, so you're responsible for keeping both safe. And so the goal, of course, delivery is a healthy mom and a healthy baby. So, and there's lots of things that we watch for during labor. Of course, blood pressure. We watch for fetal tolerance of the labor. The birth process is kind of just the end of all of it. It's not just the only part of it. Labor is only one part of one day of the whole entire pregnancy. And then postpartum care, we provide that immediate postpartum. Of course, you're looking for postpartum hemorrhages. You're looking for making sure the mom is transitioning to postpartum, as well as your newborn. There's a lot that has to be done with your newborn in the first 10 minutes of life as well, and making sure that they transition normally. The postpartum period, generally the first 24 hours is going to be your most critical time, so you're watching women for their blood pressure, you're watching them for bleeding, making sure that they're doing well that way. Preeclampsia, is not just a thing of pregnancy. Probably 50% of all women who have seizures that lead from preeclampsia that leads to seizures happen in the postpartum period. So we have to be very cognizant, and once they have a baby, they're not done. We have things that we have to monitor pretty closely for there. Okay. We see our women generally a week after they deliver, and then we see them around 5 to 6 weeks, depending. Okay. And then that just transitions us into the back to women's care. So it's kind of a circle. Our women's care involve contraception. That's always a big one after babies are born. Usually that's the first thing I ask them after they deliver, and most of them say they're not going to need it because they're never going to do anything ever again. and then I get the call at 3 weeks that asks me, how long do I have to wait? Yes. So contraception is a really big part of what we do. There are several different options for contraception for women, more so than we've ever had in the past. And I think this is again, in looking at education, this is a prime opportunity for us as midwives to teach, because people just don't know. And what they do know is not right. And so this is a good opportunity. And I think, you have the women that come in and they think all they could use was pills. Well, that's, pills are the least of what we have available for women nowadays, okay? So in the lines of contraception, for women who are breastfeeding after they have a baby, we don't want to use anything that has estrogen in it. It will decrease their milk supply, and so we stay away from those things such as birth control pills with estrogen. Now, there is a birth control pill that is progesterone only that works very well. However, if your woman's not a good pill taker, you better not do it, because she'll end back up pregnant, because they're not as forgiving as combination birth control pills that have estrogen in it as well. So they have to be a good pill taker. And if you have the 16-year-old girl who just had a baby and can't remember to take a prenatal vitamin, she's sure as heck not going to remember to take a birth control pill. You can't rely on that, and she's going to be busy doing other things. So birth control pills are an option. The depot shot is an injection of progesterone, which a woman can get once every 3 months, and it is a higher level of depot progesterone. A lot of women really like this form of birth control because, again, they can use it while they're breastfeeding. They don't have periods generally after the first 7 to 8 weeks of getting that. Now, they do have bleeding initially, and everybody needs to be aware that, just be ready for it because it's coming, and you will have this. But generally, after they receive the second to the third doses of those depot shots, then they don't have it. So women like it because of that. Side effects are greater with depot. We have a lot of women who come in with the acne, the mood swings, weight gain. Women can come in and gain 30 pounds in a month, with depot sometimes. So we have to be kind of careful as to who we give that to. But depot is a great option. You don't want to have someone on depot longer than 2 years because it decreases bone demineralization, and so we have to kind of keep that in mind, and we have to have them take calcium and weight-bearing exercise and keep track of that. Okay, so depot is a good option for the breastfeeding moms. NuvaRing, which is looks like a hairband, just a little clear ring they put inside the vagina. They can leave it for 3 weeks, take it out for a week, put another one in. It does contain estrogen and progesterone, just like birth control pills. Okay, it's just delivered in a different method, so you can't use this while they're breastfeeding. It is a great option for women who can't keep track of taking pills. They only have to think about it once every month, and that's usually a good option, a better option for women. They can leave it in all the time. It doesn't have to be taken out for sex. It doesn't have to be, I have women come in for their annuals, they don't need to take it out. So it's a really nice form of birth control for people who don't want to think about it very often. There is the patch, the birth control patch, which is a little clear patch that they wear on their hip. It's good. They have to, for once a week, they have to replace it, and they do that for 3 weeks, and then they leave it off for a week, have their period. Again, this is an estrogen-containing birth control, and so they do have to not be breastfeeding if you're going to use this with those postpartum women. Okay. Again, it's not as user-dependent, so you don't have to be taking a pill every single day, but every week you have to change a patch. One of those things that you worry about with those is if you've got the really active women who swim or something like that, that patch sometimes can get discolored a little bit, so, and they come off. And so you have to kind of look at your woman and decide, if that's a good option for them. Okay. Probably the most effective form of birth control are your long-term contraception, reversible contraception, and that's your IUDs and your Nexplanon. So an IUD is a little T about this big. It's just inserted at our postpartum exam. We just insert that up inside the uterus. Takes about 5 minutes to do. There's 2 types. There are progesterone-containing IUDs, and there are non-hormonal IUDs. The non-hormonal IUD we have available is Paragard, and it's good for 10 years of birth control if they want to leave it in that long. It's copper base, but it's not a copper piece of metal, which I think that some women have that idea that, oh my gosh, I'm putting copper in me, a metal piece. It's not. It's a little plastic with a copper little coil that goes around the base of it. How it works, it changes the pH inside the uterus, and therefore the little spermies can't fertilize the egg, and the little sperm can't go through a process called capacitation, which enables them to fertilize an egg. So, and it makes it a hostile environment inside the uterus. It does work well. It's highly effective. These long-term forms of birth control are over 99% effective. So they are about the same effective rate as, say, if you got your tubes tied, so for permanent sterilization. So a lot of women like the progesterone-containing IUDs because with the Paragard, they do have heavier and crampier periods. That's just a given with those. The Mirena, Kylena, and Skyla are progesterone-containing IUDs, and reason that most women like these is because they have decreased bleeding. By 6 months, women have 90% less menstrual bleeding with those, if they have any at all. And so we actually use this as a form of treatment for heavy periods, not just for contraception. And they're good up to 5 years in the United States. They're good to 7 if you're living in Europe. So, so it depends on where you're living in order to how long they are good for. But they really are a great form of birth control. The biggest risk with IUDs is pelvic inflammatory disease, and I'm sure you guys have seen the commercial that says, oh my gosh, you can perforate your uterus and it can cause chronic pain and infertility and scar tissue. Well, what they don't say in that commercial is those chicks have really bad sexually transmitted infections. And so if you have, a big swollen infected uterus, yeah, an IUD can perforate right through the side of it. And you can get the scar tissue and the chronic pain and all that from the infection. You don't even have to have an IUD in there. So the infection is worse if you have an IUD in place. Therefore, of course, if you're counseling your women on safe sex and all of that, then their risk is very low for something like that happening. There is bleeding when we first put them in for a shorter period of time, sometimes 3 weeks, sometimes 6. It depends on the woman. There is some cramping when you put it in. I mean, we're putting something inside the uterus, so that's something to consider. The Nexplanon is a little rod about this long. We numb women up and put it right underneath your skin here. It's an implant, and it's good for 3 years of birth control. It is progesterone only as well. It's, again, highly effective because you don't have to think about it. Once it's in, it's in. Those women tend to have a little more irregular bleeding with that, not always, but it's good up to 3 years. So for women who are busy and they're breastfeeding and they don't want an IUD, then this is a really good option. So those are the types of birth. Now, of course, I guess I should throw in there's diaphragms, which I haven't, I haven't seen one for a while, and we can fit women for diaphragm, which are just like little plastic cups, and you just slip them inside. They put them inside the vagina 30 minutes before intercourse with a teaspoon of spermicidal jelly, and they have intercourse, and if they have intercourse more than once, they got to put another teaspoon of jelly in, and then they need to leave it in for 6 hours afterwards. And so it's very user dependent. Yeah, so if they're, going to have a fun night, they gotta, it's got to be, those are good for the women who plan out Tuesday nights at 9 p.m. is when we'll meet up, so which some moms, that's pretty doable when they have, they have their schedules. So so it is a good form of birth control if it's used, which it's not used very often. So those are your options for birth control for these women, not only postpartum, but these are for all women. And I think that giving women and the options of all that are available, I think is really important in our teaching and our education, because I don't think, every woman's individual, and you don't have one that's going to say, everyone's not going to do good on a pill, and not every woman's going to do good with an IUD. You just have to kind of play it by ear and see what your woman, needs. And if one doesn't work, there's always the option of changing to another. So you have to give them that education of what is available and what we can use. With birth control, again, we do the young women clear up to the older women. I think, we have those young girls that come in, IUDs are totally okay for those girls. Not to think, there's that used to say, if you hadn't had a baby, you can't have an IUD, and that is absolutely not true. And it actually is not a bad option for girls who are very active, and if they're in sports and that kind of thing, it's a good option. So in educating women in general, I think we need to make sure we give them all that whole information. So we do primary care at our clinic as well. So primary care, in not only at their annual exams, but we do, as nurse midwives, we do asthma, we do thyroid, we do all the primary care things. I mean, I'm not going to set your broken leg, but we definitely have the option and the ability to provide women with that care, because again, you're going to find women aren't going to go see anybody else. They feel comfortable with you. They don't feel comfortable with seeing a provider they don't know. And so being able to provide primary care, I think, is important. And that's even your colds, and that's even your coughs, and all those things. So I think it's important that we give that to all of our women. And then we move through, you've got your early adolescent women where they start their periods, and we have to manage those and teach those girls, because they have one little irregular period and they think there's something totally wrong, so we have to educate them. We also have to educate our older women too. And I think in general, education is kind of our and support for women being healthy is our big push. Sexually transmitted infections, it sounds like you guys have kind of touched on those through a couple of these things, but that's a big deal, and that's important to educate. And you do have those. I was listening to your discussion, and I do have probably 50, maybe even higher percentage of girls will come in with their mom, and their mom will bring them in. And either because their mom doesn't want to talk to her about it, so she just brings her up and lets us do it. Or, there's concern, and you do have that discussion with the moms, and that's a perfect time for education for moms too. I can't even tell you how many times I go through my whole list of birth control, and then I go through get on my soapbox about the sexually transmitted infections, and the mom says, "Oh my gosh, I didn't know that." So it's an education opportunity not only for the girl but her mother as well. And so you get the right information out there, and those are the opportunities that you have to bring other girls in. There's not any time that I don't have one of those young girls in there and I say, "Now listen, I've given you all the information I have. I know you have friends out there. I know that maybe they're not able to talk to their mom, or can't talk to their mom, or don't have anybody to go to. Like, bring her up here, bring her up here and we'll take care of it. We'll talk to her." So it's an opportunity to have those girls go back and say, "Hey, I know where you can go to get birth control," or "I know you can go up here and they're going to give you something, or they're going to talk to you about this." And so you can reach out and you can get other women and other girls in there. So hopefully we don't end up with bad circumstances with those girls. So it's good opportunity to educate not only that girl, and if you give her the right information, then hopefully she's going to be able to give that to her friends, which I'm sure she's going back and talking to. So. And then, of course, on the other end, we have the women who come in at 50 and they're having the hot flashes and can't sleep and they're miserable. And menopause is a big part of what we do. We have many women who sail through menopause beautifully. They have a few hot flashes, their period stops, that's all. That's it. And then you have the women that come in and they are miserable. They are having night sweats every 2 or 3 hours at night. They can't function at work. They're grumpy. People don't want, they say they just can't, tolerate things. And they have other things like vaginal dryness, and they have pain with intercourse, and they have periods. They can be totally off the charts with their periods. Some of them will have nothing for 3 months and then they'll bleed for 3 weeks straight. So there's a lot that goes into menopause. There's a lot of things that we have to take in consideration. We look at menopause as a natural stage that we progress into, and it is a stage we progress into. Whether it's that natural, I don't know. We, as women, we're born with estrogen, not a lot. It starts to increase. We feel good with it. And when we lose it, then there are changes that occur. Estrogen is important for bone mineralization. As soon as we start going through menopause, our bone mineralization decreases. We see that the tissues in the vagina are much more thinner, and so women have a lot more problems with vaginitis. They have a lot more problems with intercourse. Libido can play into that. Women come in saying they just don't have any interest or any desire. And a lot of times, if you do a good assessment, you'll find out that probably half of it's due to having pain. And so if you're fixing that part of things, then that's good. Hormone replacement is a big deal. Here they came out with a big study that says, oh my God, everybody is going to die from their hormonal replacement. And I think it was in the 1990s, I think, is when they came out with the big WHO study. And it came out in Time magazine, of course, which was horrible because they had all these women across the nation that just stopped their hormones. And of course, then you had crazy. It was crazy. It was crazy. So I think that there was a lot of information that was based on that wasn't given correctly, and so you had a lot of women who truly could benefit from hormonal replacement and do benefit from it that have a misunderstanding at the benefits of it. Yes, there's risk. The biggest risk is heart disease, and if you look back at a lot of those studies, a good share of that was related to progesterone, not just estrogen. And so these women just, like I said, they just absolutely refused to take it, and they suffered, because they were miserable, they didn't feel good. We saw health risks just as much on the other end. So hormone replacement is a very individual thing. You have women that come in that you have to assess their risks. I mean, if they've had a history of a blood clot or a stroke, the hormone replacement with estrogen is not for them. Systemic replacement. If they smoke, a woman who smokes after age of 35 should not be on any type of estrogen-related product, and because their risk of having a stroke or a blood clot is 15 times higher. And so you have to assess the woman individually to see if hormonal replacement's right for them, and they have to be aware of all the information, the risks that go along with it. There's risk taking a Tylenol, but there are risks related to hormonal replacement. There are women that we can use certain products with that aren't necessarily harmful. So if you have a woman who has a history of breast cancer, of course you're going to not use estrogen on that woman if she had an estrogen-related tumor. However, if she's got vaginal dryness and pain with intercourse, you can use vaginal estrogen cream. So there's no increased risk related to that, and that oftentimes is the biggest issue. So we use vaginal creams. We can use preparations with estrogen and progesterone. Birth control pills are very similar to what you're giving with hormonal replacement. However, hormonal replacement is a much lower dose. So there's some women you just don't want to stick on a birth control pill because because you want to decrease that amount of hormone that they're getting. The least amount is the best. But you can use vaginal creams on women with high risk. Even history of a blood clot or a bleeding disorder, you can use vaginal creams with those women. Probably the one that we hear most about is like Premarin or Prempro, and those are the oral pills that women will take every single day. And they work very, very well. Now now they actually have preparations like a transdermal patch, so they have estrogen and progesterone patches that women can use. There's gels, there's creams, you can put that stuff in anything, And so there's really some good benefits from that. There's also some women who have a very decreased libido. We look at giving them testosterone. We all have that testosterone level, but if you have very low testosterone levels, increasing those can help your women with their sexual libido. If you give them too much, they're going to grow a penis, So you have to kind of, balance out what's going to work, they've got hair growing on their chin, then you are giving them too much estrogen or too much testosterone. So you have to be careful about what you give, but you have to give those women those options. And I think that's the key with women's health is allowing women good knowledge, good information, so they can make informed choices. And we don't look at women being sick and unhealthy, and as from a nursing point of view, we focus on health. We don't focus on disease, but we know disease, and so our goal is to make women as knowledgeable as possible regarding their health choices, so they can make the best ones for them. I think that's it. Yes?
Do you find any correlation between, say, women who have like easy periods? Is there, and they're not very crampy and they don't have discomfort with that, and then having easy menopause? Or is there no correlation there?
Not at all. Yeah, you have the women who've been on their cycles, 4-day cycles, everything's great, and they hit 48, and all of a sudden they come in just, can't sleep, they're hot flashing, pain, that kind of thing. So there's not really any correlation. I think I do find that women who are healthier and who have, are active, who take care of themselves, those kind of things, have a much easier time with menopause than women who don't. Women who smoke will have a much higher risk of menopausal symptoms than women who don't. They actually go through menopause earlier as well. The average age of menopause is about 52, average between 47 and 58, somewhere in there, but 52 is the average. Women who smoke can go in as early as 42 to 43. So it does decrease those functions. Yeah.
Is that if they're currently smoking or if they've smoked?
They smoked throughout, yeah. And of course, when they're currently smoking, that increases the risk of all kinds of things. And of course, but yes, any amount of time can increase that risk. Mm-hmm. Yes?
As a midwife, where do most of the births that you assist with take place?
I do all my deliveries at the hospital.
You do?
Yes, I don't do any home.
You don't go to the homes?
As a nurse midwife, we have that option to do home births, birthing center births, hospital births. Probably 95% of most nurse midwives, certified nurse midwives, are going to do their births in hospitals.
That's definitely the safest place would be.
If it is.
Because of possible complications.
Right. And I think that you have two extremes. You have people who believe, oh my gosh, everybody should have a home birth because if you go to the hospital, they're going to make you do this and they're going to make you do this and and I think that we sometimes, when we don't educate women well and we don't, then there's a fear factor that goes into it. So I think that people think, oh my gosh, you have to be at the hospital because if you don't, you're going to have a hemorrhage and die. Okay, so that's never almost always the case. We just don't see that very much. However, I've been doing this long enough that I don't feel comfortable in doing home deliveries because I've been in those situations where you had 3 minutes to do something and you didn't have the resources. If you didn't have those resources, you would have had a bad outcome. And so as a nurse midwife, individually, I choose not to do home births. I do give my patients the option is like, what, I can give you the best natural birth if you want, in a hospital setting where we have a nice room, it's comfortable, the lights are down, your music's playing, everything's great, but you know what, if I need a C-section, it's 15 feet down the hall. So that's where I stand, but you do have the midwives on the other end who believe that a hospital setting is going to just encourage them to have all kinds of, we're going to make them get an epidural, and we're going to make them do this and make that. You can't make anybody do anything. But if you're educating your women well enough, then they're going to know that they can have a safe birth and they have their resources available. And so I do, and you'll find that most nurse midwives do practice in a hospital or a birth setting because of the liability. Direct entry midwives and CMs depends on what state you're in. Direct entry midwives can't deliver, or I'm sorry, not direct entry, lay midwives can't deliver in hospital settings at all. It depends on what state you're in as to whether there is provisions for certified midwives. So, yeah.
Is there Waterbirth here in Wyoming?
There's not here in Rock Springs. I believe that there's a nurse midwife in Riverton that will do water births in a bathtub that you buy at the store, like the kiddie bathtubs. There is the ability to do that. We just don't have that ability here in Rock Springs. We have Jacuzzi Tubs at the hospital, but they're not for birthing purposes, just because of the design of them. But water births are available, depending on where you go.
Have you ever been exposed to a water birth at all?
Yeah, I have. It's messy. To say wow. There's a lot more that ends up in that water than a baby. No, it can be very natural. It can be very soothing for a lot of women. I do find a lot of women, if we have them in a jacuzzi tub, some women will get to a point where they're like, I can't tolerate the warmth and all that, so they're out. They want to get out at a certain point. But no, I have been in seeing water births and all that. I haven't naturally done one, just because I haven't had that facility where I've worked where I could do that. But for certain women, they love it, and dads can climb in or whatever.
Birthing things. What are like the pros and cons of having like a nurse midwife compared to a doctor?
Well, I think that, for one, I think in nurse midwives, again, our focus is on the health, and we really focus on our moms. We get to know them, we get to know what they like, what they don't like, we get to know them personally, what is their health history, their background, that kind of thing. And when you I think as midwives, like I said, we focus on our patient. We're not focusing on a diagnosis. And when you look at the difference between nursing and medicine, your medicine's going to be focused on your diagnoses and illness, which they're having kind of a big revolution too. I mean, you're seeing medicine going more towards health promotion and all that. But when you go in to see a physician, they're going to assess this and this because you have this diagnosis. That can be a medical illness. Whereas I think in nursing, we tend to be more responsive to trying to focus on health and to promote health and normalcy, as opposed to always looking for what's bad, or what can be wrong. Not to say that we're not doing that, because we need to do that. That's our expertise is knowing the norm. So if there is the abnormal, we can identify it and then take action on it. So I think as nurse midwives, I think we tend to relate to our women. Not to say that men aren't nurse midwives, because they are, but I think that at this point in time, the majority of nurse midwives are women, and so there's that relatability that I think, and women trust other women. So.
Yeah. You said that spontaneous births are what you prefer. How come there's a correlation between induction and cesarean?
Because when we're inducing, we may be trying to tell the body to do something it's not quite ready to do yet. And so we have to look at several things when we look at inducing a patient. For one, we have to look at the cervical readiness. If we have a cervix that is starting to open some, that's really soft, that's thinned out, the head is down, then her risk of having a cesarean is going to be less than the woman whose cervix is closed, thick, and high. So anytime we try to make the body do something it may not be quite ready to do, increases our risk of a failed induction, which in turn leads to a cesarean delivery for failure to progress or something like that. And so spontaneous birth does decrease the risk of that, because you're allowing your body time to progress on its own and to be ready on its own. There are situations that we have to induce. If we have medical things going on, that we've got a woman who comes in, she's got high blood pressure, and we're seeing some symptoms that could lead to further problems, and it's like, okay, it's time. There's a disease process called cholestasis that happens during pregnancy. If bile acids go up, that can increase the risk of just a spontaneous stillbirth. And so those women were like, we need to induce them immediately when they hit 37 weeks. We need to be done, because it can happen. So there's things that we have to do to induce. Sometimes we don't have a choice, but the guidelines at this point for ACNM, for ACOG, for the national standards is to not induce prior to 39 weeks without a medical indication. It used to be, you hit 37 weeks, your term, your doctor can bring you in, you just induce it. If you got a C-section, then you did, and that's not really what we're trying to go through nationally. We're trying to move towards natural spontaneous birth, which does decrease the risk of cesarean, which cesarean delivery has a higher risk factor than a vaginal birth. An increase of risk of infection, of blood loss. It's a major abdominal surgery. So yeah.
I had read a statistic that the United States has a higher maternal death rate post-pregnancy. Why do you think that is?
Post-pregnancy or during pregnancy?
Well, I guess it would be post-pregnancy.
Okay,
right after
yeah,
delivery.
throughout. I think there's a lot of studies that are going into determining that. I think probably one of our biggest factors is inadequate prenatal care. When you have these women who are lower socioeconomic status and they're not getting in to get prenatal care, that is probably the number one reason is, because generally if those women are getting adequate prenatal care, those things that we're going to see that can lead to maternal death are going to be caught. There are a few things that you never would know. Pulmonary embolism or an amniotic fluid embolism is something that happens spontaneously, usually during birth, and amniotic fluid just gets into the blood system and boom. It's usually, you would have no indication it's going to happen, and it usually within a 5-minute period you've lost this moment. And you didn't even know why. It just happens. So there are things that we can't know, but if we have adequate prenatal care, then we can look at these women and say, well, this woman started out with hypertension and she's got prediabetes and she's got these things. So we can monitor that patient, hopefully change her health, change her the things that she's doing during pregnancy to hopefully get a better outcome. But that's generally, I think, the biggest thing is a lack of adequate prenatal care for women.
I was just wondering if you saw a difference in episiotomies between the physician and the nurse midwife.
Oh yes. We've had to have discussions with certain physicians saying, this is not really the standard of care anymore. You don't cut everybody every time they come in to have a baby. So I think if they're practicing by evidence-based care, which we all know what that is, then episiotomies are not indicated anymore for any. Unless there is an absolute medical emergency where you have to get this baby out right now, episiotomies should not be done. And when I started, every single woman got one, and whether you liked it or not, that's just what you did. You got down there, you numbed it up, you cut, and you sewed it back up when you're done. And now I haven't done one for maybe 8 years, 9 years. So we just don't do episiotomies anymore because with what happens is you start a cut, and then as the baby comes through, you've already started the extension, and so when the baby comes through, it just separates, and so you can have a much higher laceration, much larger lacerations when you do episiotomies, and the healing process. Some people say, well, if you just cut straight down, then that's then you've got an easy repair. Well, it's not always an easy recovery, no matter what way it comes about. And you have less laceration and separation when you allow the body to come through naturally.
I think that goes back to the nursing and the health.
I think it does. We try to encourage women to, when they're pushing to, stretch the perineum. We do things to try to avoid tearing. So we do, massage, and we do oils and those kind of things. A long time ago, you just, pushed and pushed and pushed until you just had this kid come through, and there wasn't that time to allow the tissues to stretch and we didn't do things to help that. We just push hard, get the baby out, Or on the alternative is, the amount of women who had forceps deliveries. We do not see those very frequently anymore. We try to avoid those, but that used to be, if you were in labor for 30 minutes, they stuck forceps on you, whether the baby was up here or, and that did increase, that did have something to do with the fact that, they just cut women just to pull these kids out. And so, so our care is much different, and I think especially on the midwifery end, we really try to allow women to stretch and to, have a baby naturally through there as much as we can. Epidurals are something that, is always that, oh my gosh, I want to go completely natural, or I want to have an epidural. I don't care how we get there. Let's just have a healthy mom and a healthy baby. Epidurals are not bad things. Just gonna say they're not bad. A lot of women, very rarely do I have a woman that regrets getting an epidural. It does, in some situations, help the whole process. I have women who, in certain situations, if I have a woman who's 7 centimeters and she's been there for 3 hours and we can't get her to relax to go through, sometimes we do an epidural and they deliver 10 minutes later. So there's good things about epidural. If you have a woman who's been in labor for 20 hours and she's exhausted, I mean, there's a place for them. And we've got great anesthesiologists, and they do wonderful jobs, and the risks related to them are very low. And on the other hand, you have the women who want to do things completely natural and don't want to have any pain medications and and that's fine too, I'm not the one having the baby, it's the mother, and she gets to remember this for the rest of her life. And if she wants to have a natural birth, that's totally good with me. If she wants the epidural when she walks in the door, that's fine with me too. It's not my experience, and that's, I think, a focus too, is that I'm not going to remember this 2 months from now. She is, so you've got to give her and her family a good experience. And you can give women a good experience even if they end up with an emergency C-section. Yeah, it's not the way that they plan to go, but if you are compassionate and you are open to her feelings and what's going on with her, and being supportive and providing education, it's not as scary and it's not as bad, and when you get a good outcome, then it was all worth it. And so I think that as nurses, we have to focus on not only caring for our patients and looking at what's going on with them, but the whole picture. You got a family that's standing back behind there too that you have to take care of, which is not as priority as your mom. But if you have a dad over there who's totally losing it, you need to go over and sit down with them and say, okay, this is what's happening, and give them a little warm fuzzies too, because they're part of this whole process, and they're the ones who are going to remember this as well. It's their baby too, so you're not just taking care of a mother, you're taking care of a family. So, yeah.
What % of your patients do you actually deliver the baby? 'Cause you're not always on call, so.
I probably deliver, my patients that are registered with me at our clinic, I probably deliver 95% of the babies. Yeah, so I'm a good glutton for punishment. so I generally, my patients usually have my home phone number, and there's times when I can't be there, but Mandy, who's our other nurse midwife, I trained her, so we do things hopefully pretty much the same way, and so we try to kind of, give that patient the best experience. But I probably deliver about 95% of all my patients. So.
What about your high-risk moms? At what point do you're like?
So, as nurse midwives, we care for normal pregnancies. We do have high-risk patients, which we can either collaborate with, so I can get a consult from my physician and say I have a woman with high blood pressure, I'm not really, I just wanted kind of an opinion, so I'll ask him just to kind of take a look at her, see what he thinks. He'll say, I would do this and this and this. So those are more of a consultation type of patient. I have collaborating patients where she's got high risk, and so both of us management. We do a lot of the management together, whether I see her for her visits, I see her for a few things, he'll see her for things, we alternate back and forth with our care. If everything's looking good, then generally I deliver my patients. If I need my physician there, I'll just call him to be on hand. Or if I have a situation where I've had a woman push for 3 hours and we need assistance with vacuum or something, then I call him to be there. So I have that relationship with my physician that I can call him for anything. There are patients who are very, very high risk that usually if they're that high risk, they usually get sent to maternal fetal medicine in Salt Lake. They usually don't stay there. But we do manage as being in a rural area, we manage a lot of medium risk patients. I trained at the University of Colorado for my preceptorship and we had a nurse midwifery group, and then you had the medical group, the residency group, and if we had a patient that had a gestational diabetes positive test, we never saw them again. They got sent strict to medical, and so the nurse midwives in that setting didn't really care for high-risk patients at all. So it depends on what setting. I mean, we're here in Rock Springs, and you get what you get, and you got to do what you got to do. And so I think that's we actually do a whole lot more patient care here in a medium to even high-risk status than you would at probably a big place as a nurse midwife. So.
Any final questions for Starla?
Yes.
Yeah.
Okay, so with episiotomy, I've met so many women that they've had one, and then with every single birth, they just keep getting more. Is it just because the doctors decide just to do it?
Well, they shouldn't be. Even if you've had one, that tissue, in fact, I have women, if they even have a little cut or a laceration the first time around, second time, no big deal, they don't have anything. And the more babies you have, usually the less laceration that you'll get. And so if they're getting one every single time, that's just probably a repetitiveness of who's providing that care during delivery. Because you shouldn't have one. Just because you have one sure doesn't mean you have to have another. Same with C-sections. That's used to be if you got a C-section, you always had to have a C-section. That is absolutely not the case. Depends on what you had the C-section for and what kind of incision you have on your uterus and that kind of thing. But most women have the opportunity to have a vaginal birth after a cesarean. So I first assist for C-sections. So if we do have a woman who needs a C-section, which we have those women who've had 2 or 3 and they need a repeat, then as a nurse midwife, I continue with her care by being there and first assisting for all my surgeries. And I do the same for my GYN patients. If I have a patient who needs a hysterectomy and I send them to Dr. Mercer to have this, to have a hysterectomy, I'm there for first assisting for their GYN surgeries too. So try to maintain that continuity of care, and those are the people for 10, 15 years, and you see them in the grocery store, and you get a really great relationship with your patients. So.
Any other questions for Starla?
Hey.